Hello students, with this lecture we are going to start with upper limb. In the initial few slides we will learn about the changes which occurred in the upper limb during the process of evolution, and in the later half we will focus upon the human anatomy of upper limb. So let us start today's session. Students, during the process of evolution from apes to human, many changes were acquired. Let us see those changes one by one. Unlike primates, we humans have upright posture and we use bipedal mode of locomotion. As a result, upper limb became free from the burden of weight transmission, as you can clearly depict in the illustration present on the slide. In human, with the appearance of clavicle, which acts as a strut to keep the upper limb away from the trunk, and hence this facilitates the free movement of upper limb. Because of the appearance of clavicle, the shoulder joint is now freely mobile. However, stability has been sacrificed in humans. The slide shows on the left side hand of a primate and on the right side human hand. Here we can see that in human hand the thumb is longer. It is 90-degree rotated and is separated from remaining 4 digits. Talking briefly about the skeleton system of the thumb. In human, the thumb metacarpal articulate with the corresponding carpal bone by forming saddle variety of synovial joint. In human, the intrinsic thumb muscle are larger and 3 new muscles are present in human hand. Talking only about the name right now, they are flexor pollicis longus, which is the most powerful thumb muscle and it is absent in apes. Second is deep head of flexor pollicis brevis, and third is first palmar interossei. We will see the details of these muscles in future sessions. The slide is to show you the opposition movement which is possible in human hand, and it is because of the changes in the skeleton which has occurred during the process of evolution in the human hand. Human hand, it is capable of having 3 different types of grips. They are power grip, precision grip, and hook grip. Out of these 3 grips, power grip and hook grip were present in primates' hand as well. However, specifically precision grip is the characteristic grip present only in human hand. Talking about the pronation and supination movement of the forearm, in human, the range of pronation and supination movement is higher compared to the primates. And it is all because of the changes in the superior middle and inferior radio-ulnar joints. Human hand acts as a tactile apparatus because of the rich presence of touch receptors over the pulp of the fingertips, and they are miscellaneous corpuscles. So students, we have seen how during the process of evolution, upper limb including the hand has evolved in such a way so as to perform the precise functions in a better way. So with this, we end up the evolutionary session, and now let us start with the upper limb. The upper limb, it is divided into different regions, and this is how we will proceed with the future lectures. So let us see which all are the regions. On the anterior side, we have pectoral region. This is the pectoral region. Then we have deltoid region. In between pectoral region and deltoid region, we have a small triangular area which is called as deltopectoral triangle. Then on the posterior side, we have got scapular region. Coming back to the anterior side, this we call as arm. This is forearm, and in between arm and forearm, the joint is called as elbow joint. Then this is hand, and in between hand and proximally lying forearm, we have got a joint called as wrist joint. Now, this is the division of upper limb in different regions. Now let us see which all are the bones present in the upper limb. The bones present in the upper limb, if we proceed from proximal to distal side, we have scapula, which is a triangular bone. Then we have a long bone called as humerus. We have another long bone which is exceptionally placed horizontally in the body, and the bone is clavicle. In the forearm, we have got two long bones. One is radius, which is laterally placed bone, and the medially placed bone is ulna. Then, proceeding further distally, we have got small bones which are called as carpals. In the hand, we have got short long bones which are metacarpals, and in the digits, that is in the fingers, we have got phalanges. So, let us proceed ahead. You are aware with the term pelvic girdle. Likewise, in upper limb, we will study about pectoral girdle. Now, pectoral girdle differs from pelvic girdle in certain ways. Pelvic girdle is a complete girdle, unlike pectoral girdle, which is a incomplete girdle. This pectoral girdle, it is formed by two bones. One is clavicle and other bone is scapula. And this pectoral girdle, it is basically useful in the process of weight transmission. And the joint which participate in the process of weight transmission is acromioclavicular joint, and a very important ligament which is coracoclavicular ligament, which is one of the strongest ligament of the upper limb. Now, the joints which we will study in upper limb, these are the list of the joints. Now let us briefly see these joints. This triangular piece of bone is scapula. Over the scapula, we have got a process which is called as coracoid process. Let us see coracoid process in the illustration on the right side. This is coracoid process. We are viewing the scapula from the lateral aspect in the illustration on the right side. So this is coracoid process. Another process attached to the scapula, it is acromial process, and this is clavicle. So the joint present between the lateral end of the clavicle and the acromial process, the joint is acromioclavicular joint. This is acromioclavicular joint. Now this is a short video to show you the pectoral girdle and acromioclavicular joint. So you can see the pectoral girdle, the anteriorly placed clavicle, the lateral end of the clavicle, it is articulating with the acromial process. This is acromial process, and this is lateral end of the clavicle. They are articulating to form a joint which is called as acromioclavicular joint. So this is a diagrammatic representation of acromioclavicular joint again. This is clavicle and this is scapula. We can see acromioclavicular joint here. Now, the next joint which we will study in the upper limb is the glenohumeral joint, which is commonly called as shoulder joint. So, shoulder joint, it is present in between the socket formed by the glenoid cavity and the you can see the glenoid cavity from the lateral view in the illustration on the right side. This is the glenoid cavity, and this glenoid cavity, it articulate with the head of the humerus. This is head of the humerus, and these two bony surfaces, they articulate to form a ball and socket variety of joint, in which the socket is formed by the glenoid cavity and the ball, it is formed by the head of the humerus. So this joint is glenohumeral joint. Now let us see the diagrammatic representation of the same joint. This is the proximal end of the humerus where we have head of the humerus, and this is the scapula, and this is the glenohumeral joint. Now, another joint which is called as elbow joint. This joint is formed in between the distal end of the humerus and proximal end of radius and proximal end of ulna. This joint is elbow joint. This is the diagrammatic representation. This is the distal end of the humerus, and this is the proximal end of medially placed bone, which is called as ulna, and this is the proximal end of laterally placed bone in the forearm, which is radius, and this joint is elbow joint. Now, let us see how radius and ulna articulates with each other to form three different joints, which are superior, middle, and inferior radioulnar joint. So, this is the proximal end of ulna, this is the proximal end of radius, and this joint is superior radioulnar joint. Now, this is distal end of the ulna, and this is distal end of radius, and the joint present between the two ends is called as distal radioulnar joint. And in between the shafts of these two long bone, we have got another joint present, which is called as middle radioulnar joint. Now, let us see the joints present in between the bones which are present in the skeleton of the hand. So these are the phalanges, and the joint present between the adjacent phalanges are, this is proximal interphalangeal joint and this is distal interphalangeal joint, and collectively they are called as interphalangeal joint. Now, these are the metacarpals, and the joint present between the distal end of the metacarpal and the proximal end of the proximal phalanx. This joint is called as metacarpophalangeal joint. Now, these are the carpals, and the joint present between the carpals and the base of the metacarpal is called as carpometacarpal joint. These are the joints present between the adjacent carpal bones and is called as intercarpal joint. So students, these were the joints present in the hand. Let us see another joint, which is wrist joint now. The wrist joint, it is present in between the distal end of the radius and the carpal bones. So if these are the carpal bones, we will study the details of wrist joint, which all are the carpal bones involved, which are the ligaments to support the joint in future session. As of now, these are the carpal bones. This is the distal end of the radius, and we can see radiocarpal joint here, which is commonly called as wrist joint. Now let us learn about the embryonic development of upper limb. Let us see the illustration on the left side of the screen in order to learn the same. By the beginning of 5th week, the upper limb bud appears as an outpouching from the ventrolateral body wall at the level of 4th cervical somite up till 1st thoracic somite. The ectoderm overlying this, the distal part of this upper limb bud, become thick, which is then called as apical ectodermal ridge. The distal part of the limb bud during 6th week become flat, which is then called as hand plate. This hand plate gets separated from the proximal part of the upper limb bud by a circular constriction, which you can see here. Later, fingers begin to develop. How? The cells present in the apical ectodermal ridge begin to undergo apoptosis. As a result, the distal part of this hand plate get divided into 5 parts, which give rise to the 5 digits. Now, let us define the preaxial and the postaxial border of the upper limb bud. Imagine a longitudinal axis passing through this limb bud. Then, if we proceed from craniocaudally, then the superior border can be called as preaxial border in relation to this longitudinal axis, which acts as the axis of the upper limb bud. Likewise, the inferior border can be named as postaxial border. Along the preaxial border, thumb will develop, and along the postaxial border, the 5th digit, that is the little finger, will develop. Now, let us understand the same by seeing the video clip on the right side. Here you can see that this is the upper limb bud which is arising from the ventrolateral wall at the level of C4 to T1 somite. Now you can see here the ectoderm getting thicker over the distal part of the upper limb bud, which is called as apical ectodermal ridge. Now formation of hand plate has occurred, which is now getting separated from the proximal part by this circular constriction. Now the cells in the apical ectodermal ridge will begin to undergo apoptosis in order to give rise to the fingers. Now formation of fingers is occurring, and because of the rotation, now the pre-axial and the post-axial borders have been defined. During 7th week of gestation, the upper limb bud rotates 90° laterally. As a result, the preaxial border and the thumb comes in lateral relation to the postaxial border and the fifth digit. The extensor compartment of the upper limb now faces posteriorly. Now let us try to understand this by seeing the short video clip on the right. Here you can see that this is the upper limb bud. So this is the cranial or the superior border, which can be called as preaxial border. Now because of the 90° lateral rotation, this preaxial border will come in lateral relation to the postaxial border. So because of this 90° lateral rotation, you can well understand that any long bone which develop along the lateral border, that is the preaxial border, will be called as preaxial bone of the forearm, and the one which develop along the postaxial border will be called as postaxial bone. You can also correlate this rotation of upper limb bud with the rotation of lower limb bud. Let us learn about the dermatomes of upper limb. First of all, what do we mean by dermatome? Dermatome is the area of the skin innervated by a single spinal segment. As for an example, floor of axilla is innervated by T2 spinal nerve, that is second thoracic spinal nerve. The cutaneous innervation of the upper limb is easy to understand after knowing the embryonic development of the upper limb. We know that the upper limb bud grows as a lateral protrusion from the trunk, with first digit, that is thumb, located on the cranial side, that is along the preaxial border, which then rotates 90° laterally. Thus, the lateral aspect of the upper limb is innervated by more cranial spinal cord segment than the medial aspect. The most cutaneous nerves in case of upper limb are derived from the brachial plexus, which is a nerve plexus formed by C5 to T1 spinal nerves. However, the cutaneous innervation of the shoulder region comes from the cervical plexus, which is formed by the ventral rami of first 4 cervical nerves. To understand this better, let us see a short video clip. Here you can see that how, because of the development of the limb bud, the C6, C7 and C8 spinal, the area supplied by C6, C7 and C8 spinal segment is pulled distally. As a result, finally, the hand will be innervated from lateral to medial side by C6, C7 and C8 spinal segment. The preaxial border, that is the lateral border of the upper limb, will be innervated by more proximal cervical spinal segments compared to the postaxial border. Now let us have a look over it. You can see here that This being the preaxial border is innervated by C5 spinal segment, followed by C6 spinal segment, which includes the cutaneous innervation of the thumb, followed by C7 spinal segment, likewise C8, and the postaxial border is innervated by T1. The floor of the axilla will be innervated by T2 spinal segment. Now, this illustration on the screen represents the dermatome of the adult. Here you need to focus that the shoulder region is innervated by C4, C5, this being the preaxial border, this being the thumb. So along the preaxial border, we have C6 spinal segment, which also innervates the skin over the thumb. The second, third and fourth digit along with the palm, the central part of the palm, is innervated by C7 spinal segment, the little finger and the medial part of the palm and the proximal part of the forearm. The skin over it is innervated by C8 spinal segment, and forearm along with the distal part of the arm is taken care by T1 spinal segment. Floor of the axilla is innervated by T2 spinal segment. So on the posterior side, this is how the sequence is seen. The preaxial border, we have got initial cervical spinal segment, and compared to the postaxial border, which is innervated by T1 and floor by T2 spinal segment. On the right side, you can see the name of the nerves, which with different root values. You will gradually, as we progress with the upper limb classes, you will be aware with the name of these nerves and the area innervated by them. After seeing the cutaneous innervation of the skin, let us go further deep. Deep to skin, we have superficial fascia. Superficial fascia in case of upper limb and pectoral region consists of fat, and in case of pectoral region, it has a very important clinically important structure, which is mammary gland. Apart from these, the superficial fascia also consists of cutaneous vessels and nerves. Nerves we just talked about, which take care of the cutaneous innervation of the skin. If we proceed further deep to superficial fascia, we come across with another layer which is called as deep fascia. Deep fascia in case of pectoral region and upper limb is named depending upon the area where the deep fascia is present. As we can see in the illustration on the right side, this is pectoral region. So the deep fascia covering the muscles of the pectoral region is called as pectoral fascia. Deep to pectoral fascia, we have another layer of deep fascia which is called as clavipectoral fascia. Then when we approach the axilla, deep fascia here is called as axillary fascia. This is deltoid region. Deep fascia here is named as deltoid fascia. On the posterior side of the trunk, the deep fascia is named as supraspinatus and infraspinous fascia, depending upon the muscle which they cover. The supraspinous fascia covers the supraspinatus muscle, and infraspinous fascia covers the infraspinatus muscle. As we proceed further distally, this is called as arm. The deep fascia covering the arm is called as brachial fascia, and the deep fascia covering the forearm is called as antebrachial fascia. Deep fascia over the palm is called as palmar fascia. Now, a few words about the brachial fascia. Brachial fascia covers the arm like a sleeve throughout, and then it gives septas which divide the arm into compartment. As you can see in this illustration, this is the cut section of the humerus. Now you can see here deep fascia encircling the muscles throughout like a sleeve, and then it sends two septas, one from the lateral side, one from the medial side, which reach the humerus and divide the arm into two compartments, flexor compartment and extensor compartment. Likewise, antebrachial fascia also covers the forearm like a sleeve and then sends septas. As you can see in the illustration on the right, these are the septa, one from the medial side, one from the lateral side, and The fascia modifies to form interosseous membrane. As a result, the arm get divided into flexor compartment and extensor compartment, and likewise you will study the arm and the forearm muscles according to the compartment, flexor group of muscles and extensor group of muscles. At the level of the wrist, the deep fascia is modified to form retinaculum. The retinaculum on the anterior side, that is towards the flexor compartment, will be called as flexor retinaculum, and on the posterior side, that is towards the extensor compartment, will be called as extensor retinaculum. The fascia of the palm, that is palmar fascia, is modified to form palmar aponeurosis and superficial transverse palmar ligaments. Let us have an introduction about the arteries present in the upper limb. First, let us see the illustration present on the left side of the screen. Here, this is arch of aorta. Arch of aorta, if we see the branches of arch of aorta from left to right side, then this is left subclavian artery, left common carotid artery, and brachiocephalic trunk, which then divide into right common carotid and right subclavian artery. The subclavian arteries on both the sides, when they will cross the first rib, this is the first rib, when the subclavian artery crosses the first rib and enters into the axilla, then the same artery will be called as axillary artery when it enters into the axilla. Now let us see the illustration on the right side. Here again, this is the arch of aorta and these are the branches. This is axillary artery. The axillary artery, when it crosses the first rib, it enters into the axilla, it will be called as axillary artery. You will learn in future sessions the branches and relation of axillary artery. This axillary artery, when it crosses the inferior border of a muscle present here, which is teres major muscle. When this axillary artery crosses the inferior border of teres major muscle, the name of this artery changes as it now enters into the arm, and now it will be called as brachial artery. This brachial artery will course down, will give branches in the arm and will then descend down at the level of neck of radius, a long bone present in the forearm, which is the preaxial bone of the forearm. We will see the bone. Now, at the level of neck of radius, the brachial artery divide into its two terminal branches after giving other branches proximally. The brachial artery divide into radial artery and ulnar artery. Radial and ulnar artery will then descend down in the forearm, and after giving all the muscular branches and the anastomotic branches, both the arteries will descend down, will enter into the palm and will form deep and superficial palmar arches. So this was a brief idea about the arteries present in the upper limb. The details of these arteries will be taught to you in future sessions. There are two sets of venous system present in the upper limb, deep veins and superficial veins. Deep veins, they run parallel to the arteries and are called as venae comitatus. There is an exception to this, axillary vein. Axillary vein isn't the venae comitatus of axillary artery. Superficial vein run in the superficial fascia. For an example, a very important superficial vein is cephalic vein. Another is basilic vein. Median cubital vein, which is clinically very important vein, we will talk about it in future sessions, is also amongst the superficial vein. Other one is median antebrachial vein. Let us see the details of superficial veins first. In the illustration on the left upper corner, you can see these elevations on the dorsum of the hand. These elevations, because they are present on the dorsal side of the hand and are generated because of the superficial vein, is called as dorsal venous arch or dorsal venous network. Now let us see this illustration. The dorsal digital veins, they drain the venous blood from the digits and are joined by the veins from the palmar side of the hand, and then collectively they form this venous arc. This venous arc laterally, see, this is the thumb, so this becomes the lateral side. So this dorsal venous arc, it continues laterally as cephalic vein and it continues medially as basilic vein. So you are familiar with the term how cephalic vein is formed. It is formed by the medial continuation of dorsal venous arc. Now, cephalic vein wind round the lateral border of the forearm to enter into the anterior side of the forearm. Likewise, basilic vein wind round the medial border of the forearm and come to on the anterior side of the forearm, just like cephalic vein. Now, let us see these two veins in this illustration. Here, on the lateral side, this is thumb, so this becomes the lateral side of the forearm. This is forearm. This is cephalic vein. After it crosses the lateral border, it comes to the flexor compartment of the forearm or the anterior side or the ventral side of the forearm. Now it ascends up. In the cubital fossa, it is joined by a vein which is called as median cubital vein. Now simultaneously, let us see the basilic vein. Basilic vein, after winding down the medial border of the forearm, enters the ventral or the anterior compartment of the forearm and ascend upward. Now this median cubital vein, it is a communicating channel between laterally lying cephalic vein and medially lying basilic vein. So this is median cubital vein. I repeat, it holds a very important clinical significance. This basilic vein will then ascend upward, will unite with the vena comitatus of brachial artery and will form the axillary vein at the level of inferior border of a muscle called as teres major muscle. After crossing the inferior border of teres major muscle, this basilic vein and the two of its tributaries, which are the vena comitatus of brachial artery, will be called as axillary vein. So you can see at this level, the same vein is named as axillary vein because now this vein is located inside axilla. We will see the details of all this in future sessions. This axillary vein continues upward and once it crosses the outer border of the first rib will be named as subclavian vein. Now let us see the details of cephalic vein. The cephalic vein ascend upward initially along the lateral border of the forearm on the ventral side or the anterior side and then crosses the cubital fossa and enters into the arm along the lateral border and then enters into a groove called as deltopectoral groove, and in the deltopectoral groove or the deltopectoral triangle, it takes a 90-degree turn, dip down and drain the venous blood into the axillary vein which was formed by the union of basilic vein with the two vena comitatus of brachial artery. Then collectively the venous blood from whole of the upper limb is drained into the subclavian vein. Now this is the schematic representation to show you the venous drainage of the upper limb. Here these are the dorsal digital veins which drain the venous blood from the digits and then they collectively form dorsal venous arch. This dorsal venous arch also receives the venous blood from the palmar aspect of the hand. The medial end of this dorsal venous arch continues upward as cephalic vein. Cephalic vein will then wind round the lateral border of the forearm and enter into the anterior compartment, that is flexor compartment of the forearm, and will then ascend upward. Likewise, the medial end of the dorsal venous arch will continue upward as basilic vein. This is the basilic vein. This basilic vein will wind round the medial border of the forearm and then will enter into the anterior, that is flexor compartment of the forearm. Both cephalic and the basilic vein will then ascend upward, and in the cubital fossa, both these veins will communicate through another vein which is median cubital vein. Later, the cephalic vein will ascend in the arm along the lateral aspect or the lateral enterolateral side of the arm and will then drain the venous blood into will enter into the deltopectoral groove and will drain the venous blood into axillary vein. Basilic vein on the other side will unite with the vena comitatus of brachial artery, which are called as brachial vein, and will then form the axillary vein after crossing the inferior border of teres major muscle. Now students, in order to revise, the preaxial vein is the vein which is located along the lateral side of the forearm and the arm, and hence the preaxial vein of the upper limb is the cephalic vein. Likewise, the postaxial vein is the vein which ascends in the forearm and the arm along the medial side or the medial border. Likewise, the postaxial vein will be the basilic vein. Now let us learn about the lymphatic drainage of upper limb. Upper limb, the lymph from the upper limb is drained by two sets of lymphatics, superficial lymphatics and deep lymphatics. The superficial lymphatics are so called because they ascend along the superficial veins present in the upper limb, and we know that superficial veins are cephalic vein and basilic vein. In order to revise, the cephalic vein is the preaxial vein of the upper limb and basilic vein is the postaxial vein of the upper limb. The lymph from all the superficial lymphatic drain finally into the lateral group of axillary lymph node, with an exception to this rule is the lymphatic which ascend along with the cephalic vein. These lymphatics which run parallel to the cephalic vein, they drain their lymph into apical group of lymph node. They do not drain the lymph into lateral group of lymph node. Talking about the deep lymphatics, they are so called because they accompany the deep vein, and deep veins are radial vein, ulnar vein, brachial vein, which are the vena comitatus of brachial artery. These deep group of lymphatics, they terminate just like superficial lymphatics. They also terminate into lateral group of axillary lymph node. And the area drained by superficial and deep group of lymphatic are: superficial lymphatics drain the lymph from the superficial superficial part of the upper limb, as in fingers, palm, dorsum of the hand. And deep group of lymphatics, they drain the lymph from the deepest tissue like joint capsule, periosteum, tendon, muscles, and nerves. Ending up this session, let us compare the lower limb, which you have already studied, with the upper limb. Lower limb, we talked about pelvic girdle, which is a complete girdle formed by hip bone on both the sides and sacrum. In upper limb, we will teach you pectoral girdle, which is an incomplete girdle, which is formed by two scapulae and two clavicle. The bone present in the thigh is femur, and the bone present in the arm, which we will teach you in upper limb, is humerus. In the leg, we taught you the two bones, tibia and fibula. Tibia is the preaxial bone of the leg and fibula is the postaxial bone. In case of forearm, we will study about radius and ulna, out of which radius is the preaxial bone and ulna is the postaxial bone. In lower limb, we read about articulated foot, where we studied the 7 tarsals bone. These tarsals were arranged in 2 rows, distal row and proximal row. In articulated hand, which we will read in upper limb, we have 8 carpal bones instead of 7 tarsals in the lower limb. These 8 carpal bones, just like the tarsals, are arranged in 2 rows, distal and the proximal row. So students, with this we end up this session.